Welcome to the final plenary of this year's conference, and on behalf of my co-moderator, Dr. Hector Perez Gomez, and myself, we'd like to welcome you to this plenary. But first, as we've been doing all week, we're starting the plenary with the award of one of the union major awards. And so what I'd like to do first is to call Dr. Toru Mori from the Japanese Anti-Tuberculosis Association to tell us about the Princess Chichibu Prize and announce this year's winner. Dr. Mori.
Good morning, ladies and gentlemen. It's my great honor and pleasure to be here today at this ceremony to deliver the Princess Chichibu Memorial TB Global Award on behalf of Her Princess Imperial Highness Princess Akishino, Patroness of Japan Anti-Tuberculosis Association. This award has been given every year since 1998 by the Japan Anti-Tuberculosis Association in collaboration with the Union at the World Conference on Lung Health in recognition of the distinguished achievement to global anti-tuberculosis activities. Tuberculosis used to be highly prevalent in Japan during 1930s and 1940s. Late Princess Chichibu lost her husband due to tuberculosis at that time. She devoted herself throughout her life to the tuberculosis prevention, overcoming her personal grief as patroness of the Japan Anti-Tuberculosis Association. This award was founded based upon her will to make the world free of TB. The winner of the award for 2017 is Dr. Armand van Doorn of Belgium. For his outstanding achievement in expanding tuberculosis control in many developing countries, especially in the field of bacteriological laboratory and chemotherapy. Dr. van Doorn developed the 9-month treatment of multi-drug-resistant tuberculosis with cooperation of Bangladesh Layman Foundation Project and the Institute of Tropical Medicine, Antwerp. So far, this regimen has proved so potent that it will become a standard regimen for the multi-drug-resistant tuberculosis. Also, Dr. van Doorn has contributed greatly to the competency of tuberculosis laboratory works, including its capacity building and quality assurances. Now, ladies and gentlemen, I would like to invite Dr. Armand van Doorn to the podium to receive this year's award. Dr. van Doorn. Congratulations.
Thank you very much for Arnold. He will be very pleased. Thank you very much. He deserves it. Thank you.
Thank you, Dr. Mori, and thank you to JADA. So, the topic for the plenary this morning is accelerating lung health over the life course, and we have 4 speakers. Some of the speakers have actually asked if they can sit in the front row while they listen to their colleagues, because it's actually a little difficult to see, and I'm going to take the prerogative of the moderators and say if you want to sit down there during some of the other talks, that's fine. Okay. So, our first speaker is Dr. Madhu Pai from Canada, who will be talking to us about a time for a quality revolution in tuberculosis care. Dr. Pai.
Good morning, everyone, and I'd like to thank the union for this privilege and honor of addressing this plenary. I have no financial or any other conflicts of interest to disclose. In global health, I think we've slowly starting to understand that coverage does not necessarily mean quality. Coverage of any service is important, but then coverage alone is not going to make a big difference in impact. A beautiful example is in the field of maternal and child health. Merely increasing the coverage of institutional delivery in some settings did not actually meaningfully lower maternal or child or infant mortality, which means quality needs to be as important in our thinking as merely coverage. So coming to TB, for years we've emphasized DOTS coverage as an important indicator. And in many, many countries are now 100% DOTS covered. But that doesn't mean the quality of DOTS services or TB services are necessarily good. And I think that is the main theme or focus of some of the work we are doing. So I was asked by the Lancet Commission on High Quality Health Systems to look at TB through the lens of this quality commission. And the way this commission has defined quality is as follows. A high-quality health system optimizes health by consistently delivering care that improves or maintains health, being valued and trusted by all people, and responding to changing population needs. So based on the older Donabedian framework, this commission has provided me a framework through which I should look at tuberculosis. That was their request to me. And here is the framework. If you look at the foundation at the bottom, a good quality health system will have the foundations necessary to deliver good quality care. This is the bricks and mortar, the doctors, the nurses, the beds, the drugs, the money. All of that needs to be in place for a quality system to deliver good quality care. On that foundation rests the next stage, which is competent care. And this is, are you providing correct evidence-based care to your patients? And do your users or your clients or your patients have a good experience in your health system? If all of this went okay, this should result in good health, confidence in the system, and economic benefits, or not incurring catastrophic costs for your patients. So we were given this framework, and we essentially took all of the TB data we could find, WHO report, out-of-step report, systematic review, simulated patient work, anything that we could find, cascades of care, pathways to care, and we fit it into this particular framework. And here are the results. I'm afraid we look terrible on a global scale on the quality of care we are delivering to our patients. This one-page infographic is our way of synthesizing everything we have and putting into this framework. Unfortunately, unlike other areas of global health where foundations seem to be okay, but quality seems to be suboptimal, in TB, even our foundations are rocky. Take a look at what we have. Our financing is poor. All of us know how underfunded our national TB programs are. We're still using old tools. Access to new tools is abysmally low. We still have a whole bunch of people who are not receiving services, and our existing foundations in every single metric is poor. So I'm going to report back to that commission and say, even foundations in TB need to be improved. Secondly, if you look at processes of care, and if you look at cascades of care, 1 in 2 drug-sensitive TB patient is making it to the finish line. Less than 1 in 5 drug-resistant TB patient is making it to the finish line. We have huge numbers of people dropping out of care, and all of this results in diagnostic delays, low patient satisfaction, low confidentiality, increased costs, and nearly 2 million people who are dying every year. TB mortality is also a beacon of poor quality TB care. Now I'm going to show you data to back everything I've just said. So if you look at patient pathways to care, this report is coming out in Journal of Infectious Diseases today, I believe. Entire supplement is patient pathways cares, and this is a graphic of 13 different countries. If you look at patient pathways to care, nearly 60% of our patients are starting off outside of the National Tuberculosis Program, including a third in the informal sector, which includes private pharmacists, faith healers, all sorts of practitioners. And by the time they wind their way to this long pathway of care, it takes weeks, if not months, before they finally get linked to adequate care. And at the level of care they're seeking, at the lowest community level, we don't even have a diagnostic test for tuberculosis. And so this is one important indicator that we need to worry about, long, complex pathways to care. Next, process of care. This report was released this conference by the Stop TB Partnership. This is a crude global cascade of care. And you can see here, if you look at the drug-sensitive TB, only about half are successfully treated. If you look at the drug-resistant cascade of care, only 11% are successfully managed. This is at the global level, and it's fairly crude. The picture becomes clearer when you go to the country level. This is the cascade of care for India in the public sector, already published in PLOS Medicine, and you can see very similar results. Drug-sensitive TB, only about half of Indians in the public sector are making the finish line. Drug-resistant TB, 11% of Indian patients are making it to the finish line. South African cascade of care, being published today in that JID supplement. Same story. About half are making it to the finish line. XDR-TB, 1 in 5 are making it to the finish line. You could now go to the sub-national level and do a cascade of care, just like HIV has done for years. And it becomes very clear that too many people are falling through the cracks. Our processes of care require a lot of work. What about latent TB? Even with all the money we spend on latent TB in rich countries, barely 1 in 5 patients are making it to completing the cascade of care for latent TB. So whichever cascade you look at, you can see that processes of care are far from optimal. What about this issue of competent care? How competent is our care? So this is an international group working on quality of TB care. We've launched a website where all of our quality of TB care materials are available. We essentially have pioneered the use of simulated patient actors to assess how competent the care is. And here is what we do. I'm giving you an example. And here are all the papers we've published. We have quality of care using simulated patients in India, Kenya, China is coming out in PLOS Medicine on Monday. And here are the results. This is one of the only several simulated patients we've developed. This actor will walk into clinics and say, I have cough for a long time with fever that is not going away. And if asked, this simulated actor will give you every single clue you need to consider this to be a simulated patient. Fever, yes. Weight loss, yes. Sputum, yes. Loss of appetite, yes. Family history of TB, yes. Short of saying, please test me for TB, this person will give you every clue that you needed to be tested. And look at the results. This is data from multiple cities in 3 countries in the primary care providers in the non-NTP sectors. Virtually none of these presumptive TB simulated patients were referred. You can see the referral rate in Mumbai and Patna is 2%. Nairobi is 4 to 10%. In China, in the village clinics, is 28%, 18%. Look at correct management. Correct management is either referral or a test for TB. Any test for TB would be acceptable. Even a chest X-ray would have been a happy conclusion of this patient interaction. Most of them were incorrectly managed, which means we do not seem to have the ability to even pick up TB at the primary care level, even when it is staring in your face. And this is the non-NTP sector. If you ask me, how does this look in the NTP sector? Unfortunately, I don't have good data. We haven't done enough of this work in the DOTS programs. The only country that did it is Kenya. In Kenya, if you send a simulated patient of this nature to the public system, 80% got tested for TB. If you send them to the private system, 33 to 40% got tested for TB. My gut feeling says public will do better because the DOT system has been thinking through these issues for many years, but I would like to show that with convincing data. If we can show that, then our biggest strategy would be to deviate patients away from the private sector and get them into the public system. That would be our biggest intervention we can do, is to migrate patients away from this non-NTP sector, which is clearly not managing tuberculosis correctly. And my last comment is, can we improve quality if we did something? If we wanted to do something about it, what does QI in TB look like? Now, QI is not new. There are people who've been working on QI for decades in other areas of healthcare. There are institutions dedicated to QI. And here is what India has done. India has done an amazing QI program in the private sector in 3 different cities by the Indian government, PATH, World Health Partners, supported by the Gates Foundation, where they've aggregated a large number of private patients, educated them, given them a basket of interventions, ICT support, call center, and lo and behold, you can show notifications went through the roof, microbiological confirmation went up, treatment completion went up in every metric. And we've done simulated patient work pre and post and have shown improvements in quality of TB care in the private sector. If you can pull off QI in the toughest private market in the world, which is the Indian private market, surely there is hope for QI. Anyone can do it. If it can work in India, it can work anywhere in the world, isn't it? And so quality can be improved. But the question is, it's not going to happen organically. We've got to think about quality, put in the QI systems, and make it work. And here is the problem. Most NTPs that I've spoken to do not have a QI program built in. They think QI is EQA for microscopy. That is not what we are talking about. Every aspect of your TB control needs to be thought through the QI lens to be able to pull off. The most inspiring example I can see today is South Africa. They've just launched a QI program this year in their NTP in 10 districts of South Africa. Indian new NSP includes QI and cascade of care, thoughtfully done. And Uganda, as well as Tanzania, have pilots going on in QI. So we're just starting to flirt with the whole notion of QI in our national TB programs. And I would argue that we need to reinforce that much more. We need many more countries to adopt QI and put patient-centric care at the center of the QI. I don't think simply coverage indicators are adequate in TB anymore. We've got to ask ourselves, how good is the service we are offering to our patients, and actually measure it. If we don't measure quality, then we know we're not doing well. Cascade of care, all of them are various indicators of measurement, but I love to see even at the global level that the WHO TB report includes indicators of quality of care, and countries start tracking quality of care so that we can show improvement over time. In short, QI should be in the DNA of all NTPs. It is currently not, and I'm hoping countries like South Africa and India and others can show that it is possible to have a high-quality TB care system. So with that, I thank all of the collaborators who've helped us, and really appreciate our moderators for giving me this opportunity. Thank you.
Our next speaker will be Dr. Bassett, talking about minimally invasive autopsy.
Thank you very much. Thank you very much to the union and the organizers for inviting me. It's a pleasure to have a topic like the one I'm going to talk about put in a plenary session, and having also a full symposium like we had yesterday. So I'm going to talk today about minimally invasive autopsies and how we can use this innovative tool to understand causes of death. And I don't have any conflict of interest. And the main reason for trying to explore new methodologies for investigating the cause of death is because the current ones that we have are imperfect. And those are the methods that we normally use: vital registration systems, basically death certificates, clinical records, verbal autopsies, and postmortem examinations. And all of them have their drawbacks. The first one is vital registration systems. And we know that many people are born and die without ever being registered in low or middle income countries. This is what some people describe as the scandal of invisibility. And therefore it is difficult to actually note how many people are dying in the poorest settings. In addition to that, many people actually die without having ever been seen by a clinician. And therefore, it is unthinkable to have death certificates attributed to those deaths. In a setting like Manisa in Mozambique, where I work, over 50% of the child deaths, of the pediatric deaths, occur outside of the health system and are often unnoticed. What about clinical diagnosis? Well, we know that clinical diagnosis in rich countries are a reliable way of diagnosing the cause of death of somebody, but that's because of the abundance of diagnostic tools that are available. In low or middle income countries, the scarcity of diagnostic tools makes pre-mortem diagnosis quite bad, actually. And we've seen that by comparing pre-mortem clinical diagnosis with post-mortem pathological diagnosis, which are considered the gold standard methodology. And historically and globally, this is not only an issue in poor countries, clinical pathological discrepancies have been rather high, and sometimes as high as 50% of the cases. And post-mortem clinical diagnosis, therefore, should be interpreted with caution. And also, I just often like to show this picture because when you go back in the clinical records in poor countries, you often have a very hard time. What about the verbal autopsy? For those of you who don't know the verbal autopsy, this is just a standardized interview that a field worker conducts in the field to the family of the deceased person, asking a series of questions based on signs and symptoms that the deceased had before dying. After that, either a physician or a computer algorithm interprets the responses to those questionnaires and actually attributes a cause of death. And we know that this is a method that is widely used in poor countries, but is very unreliable. This is just an example of a narrative that goes together with a verbal autopsy in which a child was seen with fever, cough, a few days later had diarrhea, and then died. And then the cause of death was attributed as fever, and the other plausible cause of death was attributed as diarrhea. Well, you can imagine how unreliable a method like this is, but this is in many places the only thing that we have. And what about the post-mortem, the classical pathological autopsies? I would say that indisputably this is the gold standard for cause of death ascertainment, but there are very, very few or no pathologies available. In a country like Mozambique, where we have 28 million people, we have less than a dozen pathologists available. And they are all more involved in diagnosing the living than diagnosing the dead. Also, there is a lack of infrastructures. But more important than any of the two first points is the little acceptability of or feasibility of a very disfiguring procedure. No one likes, in poor countries or in rich countries, having their relatives go through a full autopsy. Therefore, this is a procedure that is seldom performed outside of legal reasons. So if we put all of this together, we understand that the majority of the world's population live in the areas where vital registration systems are inadequate, or more than half of the deaths occur outside of the health system. That the knowledge of the cause of death is critical to guide effective strategies and health planning. And that the current methods that we have, including the verbal autopsy or the clinical records, have important limitations, we can reach the conclusion that pathology autopsies are seldom performed. We can reach a conclusion that we need new methodologies. And that's the source of some of the inconsistencies in the cause of death estimates that we see today. And I've just chosen a couple of examples. One in children, the estimates of different groups regarding mortality attributed to pneumonia is about 100,000 child deaths, more or less, depending on the group you look at. And more blatantly, if you look at tuberculosis estimates, and I don't need to remind you, depending on the group that calculates those estimates, we may have nearly 500,000 deaths of difference per year. So this is the magnitude of the uncertainty. So here's where I want to introduce the MIA, the minimal invasive autopsy. And what is the MIA? The MIA is essentially a compendium of fine needle biopsies obtained post-mortem after death of the key organs and tissues, plus blood and cerebrospinal fluid, using these fine needles and producing small cylinder samples. I'm just showing a few examples of the procedure itself, how we get brain samples through the transnasal approach. In children, we also utilize the transfontanelar approach, how we get liver samples, lung samples, and these are the examples of the fine cylinders that we obtain with these needles. And what we did back in 2013 is to actually design a study to validate this methodology to replace the full autopsy. So for all autopsy cases, we conducted first the minimal invasive autopsy by a first team of pathologists, and then the team left, and a second team of pathologists entered, and in the same corpse conducted the complete autopsy. And then on a blinded manner, we compare the results. Importantly, the samples that we obtain with the minimal invasive autopsy are subject to histopathological and microbiological evaluations. And we actually reach a cause of death. And what have we learned from this exercise, from this study that we did? The first thing that we learn is that the MIA procedure successfully obtains samples of the major organs, which are adequate for histological and microbiological analysis. The cause of death is identified in a high proportion of cases, and there is a very strong correlation between the results of the MIA with the full autopsy. The MIA also allows a cleaner investigation of infectious diseases, and specific pathogens are more readily identified and associated with the cause of death using the MIA tool. And what about acceptability, you will say? Well, we also conducted an acceptability and feasibility study in 5 countries, together with the validation of the MIA tool, which essentially gave us the conclusions that next of kin of deceased people were willing to know the cause of death of their deceased family members. There was a high theoretical acceptability of the MIA tool, which has been confirmed once we have implemented the MIA tool for cause of death surveillance in poor countries. I've chosen some examples of lung disease to illustrate a little bit what we can get with the MIA. Obviously, this is a picture from the full autopsy, not from the MIA, where we can see a TB cavern, and then we can confirm with the histopathology, obviously, that the presence of Mycobacterium tuberculosis. Other examples, disseminated Kaposi sarcoma of the lung, pyogenic pneumonia with a lung completely infected with pus, pneumocystis pneumonia, cryptococcal neoformas infecting the lung. And I've chosen a couple of simple examples to illustrate how difficult it is to diagnose pre-mortem and how easy it becomes post-mortem. The first one is a 33-year-old male, HIV positive on antiretroviral treatment, which showed signs and symptoms on admission of fever, cough, dyspnea, diarrhea, and abdominal distension. Had very elevated creatinine values, and the clinical pre-mortem diagnosis was AIDS and renal failure, and got antibiotics which were not specified in the clinical history, and died after 7 days in a hospital. And when we actually looked at the pathology and the microbiology, we saw disseminated necrotizing granulomas in the liver, in the kidneys, in the lungs, and in the spleen, plus a confirmation by PCR of positive Mycobacterium tuberculosis in the brain, lungs, and cerebrospinal fluid. This was a very clear miliary tuberculosis case. These are just images of granulomas of the lung and of the kidney. And finally, my last example is a pyogenic pneumonia that the pathologist could not define better. And this is a picture of the macroscopic aspect of the lung, which was full of pus. If only the pathological exam had been done, we would have been left with a pyogenic pneumonia as the cause of death. But the microbiology using the MIA samples allowed us to detect Acinetobacter baumannii in multiple organs. This was an HIV positive patient. And the PCR confirmed this Acinetobacter baumannii in the 3 organs, plus also detected it in the blood and the CSF. And importantly, because we could isolate the pathogen, we could test the antibacterial resistance, and this was a multi-resistant strain. So with the MIA and with the advanced microbiological techniques that we applied, we could diagnose an Acinetobacter baumannii sepsis from respiratory origin. So in conclusion, this is my last slide. The models utilized to build estimates for cause of death in poor countries, where the majority of preventable deaths still occur, have shown many flaws. Discrepancies in cause attributable disease figures have evidence that shortfall of current methods, predominantly based in data derived from verbal autopsy or clinical records. Minimally invasive autopsy methods have the potential to substitute the full autopsy. This method appears significantly more acceptable, but still provides good quality tissues amenable to robust diagnosis. And through the establishment of surveillance sentinel sites using minimal invasive autopsy for cause of death investigation, more evidence-based estimates of cause of death in low-income countries will become available. And I need to thank the team and my co-PIs in the study, Dr. Jaume Ordi, the pathologist, and Dr. Clara Menendez, and also the entire team in Maputo Central Hospital and all our partners. Thank you very much.
Good morning, ladies and gentlemen, and welcome to Guadalajara once again. Let me introduce to Dr. Katharina Boehm. She is the Chief Executive of FIND in Geneva, Switzerland, that drives the development in delivery and diagnostic tests in diseases of poverty. Under Catherine leadership, 10 new diagnostic tools have been introduced in resource-poor settings. She has expanded FIND's scope to introduce outbreak preparedness, hepatitis elimination, and antimicrobial resistance. She is the chair of the new diagnostic work group in the Stop TB partnership and serves on several public health advisors committees, and she has more than 100 publications. Please, Dr. Catarina Boehm, and welcome to Guadalajara also.
Thank you very much. We've come a long way in TB diagnosis over the last years. We have 6 new tests approved and over 15 best practices widely disseminated since 2005. We see a finally diversified R&D pipeline on the molecular side, and in fact we'll have several new molecular tests come to market for TB within the next 2 years, both at centralized as well as decentralized level. We'll have the tools we need to introduce the new regimens that will come out by 2020. And we're also having seeing strong biomarkers and see a continued push for non-sputum point of care with some confidence that by 2020 we will have a true point of care triaging test, not from sputum but from blood or urine. Yet the out-of-step report published some months ago highlights the very incomplete implementation efforts by countries. And what you see here on the left is way too much red on the slide, right? So very few countries implemented WHO policies, and there's only few green countries that actually show wide implementation of these 4 exemplary policies from WHO for new TB diagnostics. And we often forget that this comes at an impact to lives and livelihood. Madhu expressed it earlier on, this is case detection and prevention really is our bottleneck today to ending TB. And when you speak to the patients that are here and the survivors that are here, most of them have a very long pathway to diagnosis still today. In the case of this patient, for example, it was 12 months until he finally got diagnosed with XDR-TB through expert. So we've understood for many diseases, but really in a very painful way for TB over the last years, that technology alone is not enough. We've learned that it is about health systems and that we need to implement new tests as packages. We need to look at everything from support and supply chain to connectivity and IT if we want to see impact of new tests in countries. I think what we also have to accept that implementing best practices will not get us to where we need to be, and that what we need instead is effective, context-driven strategy that are informed by community practices. So moving from best practices to wise practices. And these wise practices are really a triangulate between best practices, national objectives and strategy, and the local context. And I think really this is the only way to get us with diagnostics where people seek care. I'd like to show just 2 examples to illustrate what I mean by moving to wise practices. One from Lesotho and one from India. So this is a project done with the government of Lesotho to improve the testing cascade to meet people where they actually seek care. Lesotho is implementing or trying to implement the WHO policy to test by expert all presumptive TB cases. What they actually see, though, in their facility-based screening program is that 60% of patients do not get tested. What they also see is that when you look at the expert utilization, it's very low, basically across all centers, with very few exceptions, as shown on the upper graph in the right side. So we've deployed with the government a new mapping tool that allows us to map patient pathways and basically allows us to map the diagnostic network in the country to see what goes wrong and what we can do better. So what we see in Lesotho is long sample and patient referral pathways really leading to diagnostic delays and patient loss. These new mapping tools allow for some quick wins, right? They inform planning and they inform placement. So there are some things that can be done rapidly, such as shifting the instrument base, which is something that was done in this case, to actually meet patients where they come and present and use the expert instruments in this case that are available. Also do things like adjust the sample flows across district borders. And then there are more complicated actions that really require the understanding of patient needs and community needs, such as in this case the placement of or intensified placement of riders for health to actually mobilize patients to present for screening. So really this shows that the mapping is an opportunity to speak to patients, to speak to communities, and allows the development of context-driven wise practices. My second example is from India about childhood TB. As you all know, we have about 200,000 TB deaths in children under 5 per year in 2015. Nearly all of those children are diagnosed just empirically, clinically, and never got treatment. In India, over 80% of clinical TB cases, or TB cases in children are diagnosed clinically. As you know, the WHO policy is to use expert as upfront test for children with symptoms. And so we worked with the Central TB Division and the Indian government to implement a large-scale pediatric TB project to basically inform the Indian policy on TB diagnosis and management in children. And really, what helped make this project a success was a very low-cost intervention focused on engaging providers in public and private facilities. It was, yes, there were components about, of course, rapid and free specimen transport, reporting linkages, getting the results back within less than 24 hours and putting patients on treatment in a short time. But really, the magic ingredient was the provider engagement, the systematic mapping of providers, both in the public and private sector, the ongoing sensitization and education, and then very basic free service offerings such as a telephonic hotline. The demonstrated value of this provider engagement model led to policy change in India and the rollout of such a wise practice policy. In 3 years, we've screened nearly 100,000 presumptive cases. 7% of these children were TB positive, and we actually found very high rates of rifampicin resistance, 9% rifampicin resistant cases. The case detection rate has increased 3.5-fold, and there's also a significant higher number of children that were placed on treatment. And this project has now transitioned to the national program and is being expanded, or has already been expanded, to 9 major cities in India. Importantly, we see a countrywide demand from private providers to be included in this project. And so I think it really shows how we can work together with providers, also on the private side, to make a difference to our TB patients. So if we are going to reach NTB, we need innovation, and we need diagnostic innovation to reach the 4 million missing cases that we have per year. But innovation doesn't matter if it doesn't reach the patients. So we need to be realistic about what technology alone can bring, and what I'd like to urge us all, patients, communities, all of us in the room, to work together with the private sector, with countries, to develop over the next years wise policies, success stories that we can actually implement, so that we can make a greater difference with the tools we have, but really are prepared for the best that is yet to come. I think the UN General Assembly gives us this opportunity. And if we could compile these wise practices in time and make sure that policymakers see these success stories, I think together we can make a big difference. Thank you very much.
Our next speaker is Enrique Delgado. Enrique Delgado holds a degree in economics and master in finance. He's important has participated in several international TB conferences as a speaker and advisor, making possible new projects in different countries, supporting national programs of TB, and making contact with parliamentaries to involve them in the reality of TB. A promising career in telecommunications saw him traveling extensively in America Latina. It ends when he contracted TB in 2009. He is engaged with civil organizations in 3 countries, advocating for better healthcare systems, patients' rights, and better medicines. Enrique is member of Frente Parlamentario de Tuberculosis de las Américas, Community Research Advisor Group, and the Unión, and the Panama TB Civil Society. Gracias, Enrique, por participar en esta importante conferencia, y muchas gracias además por compartir con todos los asistentes estas importantes experiencias. Por favor.
Well, good morning, everyone. I want to thank the Union for having me here once again. And it's an honor for me and a great pleasure. And I really appreciate your disposition in order to hear some facts about TB that we have to deal with beside the treatment itself. My war against XDR-TB took many battles. Some battles I fought alone. Some battles I have my army, but this war cost thousands of dollars for me, and it took 7 years and traveled to 4 different countries to win it. I am lucky to belong to the 20% of patients XDR who have survived. By the year 2009, I used to work in Panama in a multinational electronics company. Because of the nature of my job, I used to travel a lot all over Latin America and Caribbean. In September 2009, after a busy schedule of trips, I started to feel weak, night sweating, and all the other usual classic symptoms that you already know about TB. But it was an intense pain in my back that makes me go to the doctor. And later, a chest X-ray shows a cavity on my right lung, like this size, a coin of 25 cents. Immediately, I have to be hospitalized and start the treatment, in this case, a standard regimen. I was declared cured in February 2010, but in April, I relapsed with TB symptoms and confirmed by smears. At that time, the diagnostics capacity, availability of drugs, and experience of MDR-TB treatment and management in Panama was scarce. As I didn't have access to drug susceptibility testing, I was empirically prescribed with some drugs plus new ones as moxifloxacin and clarithromycin. Both of those were not provided by the National Program Tuberculosis, so I have to search by myself the best option to buy them. In March 2011, I was declared treatment failure based on a sputum smear and chest X-ray. In all these years, and after 2 treatments, I was imagining and asking myself, as any other person who has family, who have kids, who have parents, imagine yourself living away from your family to protect them, because at that time, I was very afraid of contagious about my family. Imagine yourself taking more than 15 pills every day at the same, and to carry an intravenous system to receive another medicines. It was in the 3rd treatment. All the things, imagine yourself trying to avoid feelings or questioning why this is happening. This is a question I already left behind, but it's really hard to think about it. So, knowing all the time without the right treatment and the chances to I have to learn more affected, I decided with the doctors make me a right upper lobectomy to increase the possibilities for the next treatment. The surgery took 7 hours. Upper lung was totally damaged and the recovery was very painful. I knew at that time I have to search other options for the treatment in other countries. And I find out that Peru was a good choice. I contact some doctor of national program in that country, and their willing to help was amazing. I traveled to Peru in May 2011, and the NTP offered me an MDR treatment available. I had to live in Peru almost 4 months, but I was responding good for the first time in the new treatment. Unfortunately, after a few months, culture results showed that I was resistant almost to everything, declaring XDR-TB. Despite that, and for the difficulties to make an XDR treatment due to medicines availability, hospitalizations, and expertise management, I continue with the MDR treatment. During 2012, all bacteriology results were negative, but I faced great problems with the medication shipments, drug purchase, expiration dates, and one of the battles I have to fight also against the system. Finally, in May 2013, after daily injections for 8 months and nearly 22 months of almost daily nausea, vomiting, among other psychological, emotional, and physical symptoms, I was declared cured. In October 2013, I was invited for the Union World Conference in Paris to present my experience and the support of the employers give to me. But once again, in March 2014, only 1 year after being declared cured, a mild cough emerged. I got a CT scan which showed minimal bronchial inflammation. Smears and cultures were negative, but I was aware that bronchoalveolar lavage samples yielded superior performance, so I did it privately. Test indicates Mycobacterium tuberculosis with resistance, meaning a relapse after 5 years of war and many battles, physical, economical, emotional, desolation feelings. Once again, I have another battle to fight. The availability of medication plus high drug and hospitalization costs and a lack of experience treating XDR cases made treatment virtually impossible in Panama or Venezuela. And Peru also was a very complicated scenario for long-term treatment. So I have a great luck to know in Paris Union Conference, Dr. Ignacio Monedero from Spain, awesome person and very dedicated to the cause. Plus, it was an expert in MDR treatment, TB. So in that opportunity, he told me that in Barcelona, there was a specialized clinic on TB. Destiny or not, thanks for Ignacio's advice and support, in 2014, I started an XDR treatment in Cervez Clinic in Barcelona. I carried a certain life for 2 years, but in this time, loneliness, isolation, and guilt feelings appears repeatedly. The drug's side effects did not help. It is easy blaming sometimes patients for default, but when there is so much already lost and there is no clear future, the line for default is too narrow. Give up or dying presents as appealing solution. I want to mention in this time the importance of new drugs, new medicines like bedaquiline and delamanid to avoid those hard side effects. I have 2 friends, Fumesa and Nandita. They were affected by those treatments. And I was very lucky because I lost just like 20 or 25% of my left ear. I was didn't treatment with bedaquiline or delamanid, just linezolid, but I want to present that is very important to try to find global access for that medicines. My treatment ended in July 2016, and I'm cured. But I miss a part of my lung that will limit my breath forever. I present paresthesia, lost part of my audition, but at least I'm not completely deaf. But most important side effects are not visible. The more than 20 cumulative days under respiratory isolation was a horrible experience. Suicide thoughts almost break my willing to go on. I lost a precious time with my daughter. I lost my career, and my family struggled for a while financially. So I started to start over again, trying to stabilize my life in many aspects. Tuberculosis is a disease of the mind and the body. The stress of being diagnosed and jeopardize the future of your life, and to deal with it, the effects of the treatment will adversely affect one's disposition as well. Healing the body will be easier if the mind is free of worry. As has been established, however, diagnosis and treatment come with severe physical and psychological stressors for the patient. It should be obvious that the treatment should have not just physical component, but a social and emotional one as well. We should understand when any person in treatment have to take sometimes more than 18 pills daily, producing nausea, vomit, headaches, stomach aches, and other bad sensations. The treat to the patient from the nurse of healthcare workers is crucial at this moment because of the good willing to be comprehensive and kindness to encourage him or her to take the medicine is one of the things that most of the patients really appreciate. Healthcare workers can be especially influential here, but keeping the patient on target and spotting some of the more extreme treatment side effects, such as suicidal thoughts among those taking cycloserine, one of the antibiotics to treat MDR regimen. And why is that so important? Because it could make the difference between continue the treatment or abandon it. There is a narrow line on this because of these side effects. Moreover, when the treatment is over 6 months. So I like soccer a lot, football, and I try to gather things. This match, we can easily win, and I think we have to understand that we are a team. We cannot do it alone. So with the support of the government, the policymakers, OMS, NGOs, research and development. In the middle, in the forward, the patient, national programs and pharmaceuticals. On the defense, global fund, funding projects. And on the goalkeeper as a civil society. So this is a long-term fight. I think we can win this match as a team, as I said. I like a lot the Liverpool football team phrase that says, "You will never walk alone." And I think for this time, together we win. So thanks a lot for hearing me.
We have just a short bit left, and I understand,
There's a guy who walks around.
Dr. Pai, I understand that you have a short film for about 2 minutes that's been loaded. Oh. Is that ready? I see somebody saying yes in the back.
There's a guy who walks around in our trains, our hospitals, and even down that road. He's got a long name that no one talks about. He's poor, doctors say, without a doubt.
His name is Tuberculosis. We call him TB for short. You can't miss him. He's there everywhere. But no one talks about this man, even though he can kill. Thousands die every day. The number should have been nil.
TB is a name that silences many of us. No one wants to talk about it. Why? Because lung TB is infectious and no one wants to be treated as less. So let's just keep our mouth shut, shall we? It's for the best.
I lost my husband and son to TB. I got it too, but doctors cured me. My husband and son were misdiagnosed and their treatment was too delayed. I survived the disease, but it took away my all, including my faith.
Did you know that TB can affect any part of you? Don't feel bad. I didn't know it too. It can sit in your intestine, or your brain, or your bone, or even your testicles and uterus. It won't leave that alone.
I had TB in my lymph node, which is not the contagious kind. It is called extrapulmonary TB, which is not a rare find.
What is the big deal, you ask? Let me tell you now, so that you know. TB has become drug resistant and the treatment is tough. The drugs made me sick and had severe side effects. Yes, I'm thankful that the disease did not kill me, but it did leave me deaf.
TB is a preventable and a curable disease. And I got to tell you now, there is no need to panic, please. The treatment may be straightforward or may leave your world upside down. But hey, we all survived. And that's how we got so strong.
I do think it's actually very clear that from this symposium, the real messages are quality programs, data needed, patient-centered care, and I love the title of wise practices. So I'm afraid at this point in time we'll need to close the symposium, but our speakers will be up here for just a few minutes if anyone would like to ask questions. Thank you very much and enjoy your last day of the conference.
chica más. Después de 5 minutos ya